اهلا بحضرتك يا فندم، الف شكر على
كده تمام يا فندم.
تمام كده
تمام يا فندم.
بعد ما حضرتك تعمل لي سلايد والتاني هنقفل احنا المايكات من عندنا بقى. اتفضلي
بسم الله
حضرتك.
الرحمن الرحيم. ماشي يا فندم، اوكي تمام. بسم الله الرحمن الرحيم. النهارده باذن الله هتكلم على مواضيع يعني متفرقه بس يجمعها البيدياتريك ني. الاطفال they present with different problems in their knees and later on as they develop and then later on as they mature. These problems, they all constitute the pediatric knee problems, and I will not talk in detail about every single entity, but at least I will highlight some of the important ones. The items I'm talking about today are hyperextension deformity or congenital knee dislocation. Congenital dislocation of the patella, a rare problem, but it is present and needs a high index of suspicion to diagnose. Fixed knee flexion contractures we meet every day. Coronal plane deformities, overuse conditions, and I would recommend a few other topics for those who need to further read into the topics. Very important and need very specialized management. Let's start with congenital dislocation of the knee. It presents in 3 grades or 3 types or 3 stages or 3 modalities. The easy ones are the type A and B, and these include only congenital hyperextension or congenital subluxation when there is actually contact between the head, the articular surfaces of the distal femur and the proximal tibia. But then there is the very serious congenital, true congenital dislocation, which is irreducible, which is type C, where there is totally lost contact between both articular sides, and any further flexion or attempt to reduce would not result in actual reduction. The management is very simple for types A and B. The knee reduces with gentle flexion and traction, gentle stretching of the quadriceps mechanism, and then serial casts can be applied to further stretch out the quadriceps mechanism or the extensor mechanism. Type C, which is true congenital dislocation, mostly needs surgical reduction because surgical significant fibrosis and shortening of the quadriceps mechanism exists, and the tibia does not reduce back onto the articular surface of the femur on manipulation. Most cases are bilateral. Most cases are mostly syndromic with arthrogryposis. They are associated with other congenital anomalies. This scene or this presentation is very common actually. A child with bilateral hip dislocation, bilateral knee dislocation, bilateral club feet, mostly sometimes with arthrogryposis or spinal dystrophism as well, which is spina bifida and another presentation with, you know, dysplastic left hip, but frankly dislocated right hip. Both knees are dislocated. They develop because of abnormal intrauterine knee position or hyperextension, which associated with lack of movement due to muscle fibrosis or little room available, results in shortening and contracture of the quadriceps mechanism. Iliotibial band, the lateral side is also very tight. That's why sometimes with trial or attempt at reduction, the tibia actually subluxes or subluxates laterally on the femur, but not reduces into position. Cruciate ligaments sometimes can be absent. To start with non-operative treatment for the easy types, so type A and B, the hyperextension and the subluxation, it begins as soon as possible. I start in the first week of life. I start to apply gentle traction and flexion, reducing the condyles of the femur forward and pushing the tibial tuberosity backwards very gently to reduce the knee, which is usually palpable. The reduction is actual and it happens right under your fingers. More flexion of the reduced knee can be achieved by applying serial casts. So you start maybe in neutral position, and then you apply the next cast 1 week later in more flexion, and then the third cast maybe in 90 degrees flexion. And I keep that last cast for at least 2 or 3 weeks to allow the articular surfaces to take the normal shape and to be congruent, and which actually is the preventing factor from developing redislocation or recurrence of the problem. Authors speak of femoral nerve block to relax the quadriceps muscle to allow that procedure to occur. Some inject botulinum toxin into the quadriceps muscle. I haven't used any of these, and I'd like to know if you have any experience with these modalities. Applying splint after you've achieved full reduction for types A and B is something I haven't seen much because they are really very stable after you reduce them. But maybe because some cases do recur, do redislocate, some authors also recommend the use of a splint to prevent redislocation. In type C, surgical treatment should be initiated for irreducible ones as soon as possible, as soon as the child is fit and surgery can be performed with safety. 6 months would be fine, up to 12 months. What you need to do is to lengthen the quadriceps tendon. A VY-plasty is the most spoken of in the literature, but the Z-plasty is the most I've done. And I think the length you need to achieve has to be achieved through a Z-plasty or Z-plasty. Medial and lateral retinacular or the parapatellar areas need to be open, the anterior capsule on both sides, so that the knee is actually allowed to reduce. When you immobilize afterwards, you need to mobilize in 30 degrees flexion, not excessive flexion, because these children are usually arthrogrypotic, and if you flex too much, you might not be able to extend later on. And be aware of redislocation inside the cast. Some colleagues and some authors use temporary K-wire fixation into the femoral intercondylar notch to prevent redislocation of the patella forwards. But, you know, as much as you can, try not to use hardware or intra-articular wires. Some authors speak of femoral shortening to spare the quadriceps muscle from scarring and decrease the need to lengthen the quadriceps. So they shorten the femur instead, which is very helpful if you need to address the hip at the same time. So if you need to reduce the hip and reduce the knee on the same side in a child with both joint dislocation, you can shorten the femur, and that will achieve most goals. Our esteemed colleagues at Assiut University published this paper 2 years ago, and the procedure entails a similar thing to percutaneous Achilles tenotomy. They tenotomize the quadriceps tendon under general anesthesia through a minimal incision, and they achieve the full knee flexion. And the rest of the quadriceps muscle can restore the knee extension later on and with good function. The second entity is congenital dislocation of the patella. It's a difficult thing to diagnose because, first of all, it's very rare, and but it happens in sometimes familial, sometimes bilateral, mostly bilateral. This case has unilateral congenital dislocation of the patella. As you can see, the other limb is totally normal. The right side, it has an abnormal flexion deformity. It's very hard to see the patella because it hasn't ossified yet. And it's where you don't want it to be. It's very, very adherent to the iliotibial band on the lateral side. It's abutting the lateral femoral condyle. The valgus deformity, flexion contraction, as we can see, the tibia is externally rotated, so that actually the tibiofemoral joint is also not nicely reduced in this abnormality. The extensor mechanism is all to the lateral side. Even the patellar tendon insertion is slightly laterally displayed. It can be difficult to interpret because the patella hasn't ossified until the age of 3, and if it's not in its normal place, it actually the ossification occurs. Management is surgical because you cannot achieve reduction with irreducible patellar dislocation. So is to lengthen the lateral structures, lateral capsule, the iliotibial band, lateral part of the quadriceps, sometimes the biceps femoris. Medial plication, medial capsule has to be tightened or overlap the patella after you reduce it to increase the tension on the medial side and prevent redislocation. Quadriceps muscle needs to be lengthened. The entire extensor mechanism, with or without actual the patellar tendon insertion site be medialized. After you're done with all that, you can immobilize the knee in 20 degrees flexion. This is the original technique where he removed the patellar tendon insertion totally, changed the position of the patella so he can other hole inside more anterior than lateral, and then reinserts the patellar tendon into a new side of the front of the tibia. Like to and medialize the lateral half so they do have a secure insertion of the patellar tendon in case the new site does not fully heal.
بعد إذن حضرتك دكتورة ناريمان آسف للمقاطعة، لو حضرتك بس تعيدي آخر 30 ثانية بس لأن الصوت كان بيقطع فيهم.
Okay. I was explaining the Langfield technique, the original technique, where he used to remove the whole extension mechanism, of course, lengthen the quadriceps tendon here proximally, but transfer the patella from its original lateral side to a more anterior position, and then reinsert the patellar tendon into a more medial position on the front of the tibia. Other authors, later authors like Orthopaedic, they do not concur with moving the whole insertion side of the patellar tendon. So they split the patellar tendon in half longitudinally, and they medialize the lateral half so that they have a secure attachment or a secure footprint of the patellar tendon on the tibia in case the new insertion is not fully healed. Of course, with plication of the medial side, the medial capsule can overlap the patella and prevent further dislocation or redislocation. Of course, the complications in this case are, number one, the recurrence of the dislocation, sometimes extension lag, because you need to lengthen the quadriceps mechanism a lot to achieve reduction of the patella in these cases. And of course, correction of the valgus and the external rotation of the tibia in an acute manner can predispose to peroneal nerve palsy. This is the same girl I showed in the previous slides a few months after her surgery. And this is her with flexion just over 90 degrees, which is functional in her case. She had a fixed flexion deformity, now she does not, and generally she's happy and well satisfied. There's another type of dislocation of the patella which does not actually present at birth. It's habitual. It does relocate and dislocate again with flexion and extension. So in the extended position, the patella reduces, and with flexion, it pops out and moves to sit on the lateral condyle of the femur. It usually presents at the age of 5 to 10 years. The child has a normal range of motion. Usually, parents do not detect its congenital nature. They say the child fell or the child sustained an injury to the knee, and since then the patella has been popping in and out. It's just when they noticed it. Fixed knee flexion deformity is a very important entity in pediatric knee problems. I'd like to highlight the normal physiologic flexion deformity in the newborn. That every newborn with flexion neonates of their intrauterine, they do sustain some flexion fracture of their knees and hips, which is a very normal function is full, and the further flexion is not disturbed. This should be regarded as normal, and it of course corrects with time, gradually reaching full extension within a few months. As long as there is no associated neurologic conditions or back problems, myelomeningocele or spina bifida, even occulta, we should not suspect any abnormality. Pathological causes of knee flexion contracture include arthrogryposis, pterygium syndromes. The picture we see is a popliteal pterygium which is a cord-like web of the skin and underlying tissues, preventing any extension of the knee. A very unfortunate problem. Lower extremity deficiencies like congenital femoral deficiencies, tibial hemimelia, especially with total absence of the tibia, result in knee flexion contracture. Congenital dislocation of the patella, as we just explained, is one of the causes of fixed knee flexion deformities. Sacral agenesis, myelodysplasias are all causes of paralytic types of knee flexion deformity. Skeletal dysplasias do present with knee flexion as well sometimes. What to do? You need to assess the whole child, the whole limb function. For example, in cases with tibial hemimelia where the tibia is totally absent, the extensor mechanism is also totally absent. So if you prefer to lengthen the posterior structures, the hamstring release, in the absence of an extensor mechanism, recurrence is 100% guaranteed. So you need to assess the flexor group, the extensor group, the functionality of the patient. A wheelchair-bound patient that is not able to stand, even with support, will unequivocally develop recurrence of the flexion deformity, because this child is sitting in a wheelchair all the time. So if you lengthen the hamstrings and do not provide standard therapy, as in physiotherapy sessions or a standard device at home where the child can actually maintain the upright posture and knee extension, recurrence will be guaranteed. Mild cases like 30 degrees, 40 degrees do not need surgery. You can further extend by serial casts or even cast wedging, which needs to be done with caution because wedging is a serious thing to do in a cast. Surgery is needed for higher degrees of flexion. You start with posterior soft tissue release, you lengthen the hamstring muscles, and then further dive into the wound to open the posterior capsule of the knee, but you need to be aware that the sciatic and the popliteal vessels run in the middle, and you cannot lengthen these. So your lengthening of other structures should not put excessive tension on the important neurovascular bundle that runs directly behind the knee, or you will lose vascularity and lose the limb, or you will lose the nerve supply. In cases where you can perform an anterior hemiepiphysiodesis, it should be done. In children with who have not reached skeletal maturity, you can fuse or simply stop or halt the growth on the anterior epiphysis or anterior half of the physis, and allow the distal femur to grow on the back so it gradually extends, which is a successful method to treat skeletally immature patients as well, which is, of course, our children. I'll jump to the coronal plane deformities because this is what we see most. We all should be able to recognize this drawing or this diagram. The normal anatomical and mechanical axes of the femora and the tibiae should be very much embedded in our thinking, and we should be able to assess an X-ray and measure each and every angle of these to detect the site of the deformity and perform the corrective procedure at the site of the deformity or the cora or the center of angulation or rotation. Bow legs can be normal. In all children less than 2 years, this is normal. They appear to be divided between the femur and the tibia, so it's not tibia vara, it's a varus deformity of the whole lower limb split between the femur and tibia, and the child has to be less than 2 years of age. At 2, the children usually get straight limbs, and then later on they develop physiologic valgus. Abnormal causes of bow legs include rickets, of course, Blount's disease, which I'm sure was nicely spoken of in the earlier lectures a few days ago. Trauma, malunion, or physeal arrest can result in abnormal growth and then result in deformity. Osteogenesis imperfecta due to fracture and healing, and fracture and healing results into bowing of the bones. Metaphyseal chondrodysplasia, like this one, mostly results into a bow leg or varus deformity of the knees. Knock knees, on the other side, is the other side of the deformity. Physiology begins to show knock knees at the age of 3 years, or peaks at the age of 3 years, and it can stay until the age of 6, 7, or 9. So we shouldn't really rush in correcting valgus knees in children around the age of 3, 4. We should wait until they're a little older and they're not improving with vitamin D and calcium. These include rickets, renal osteodystrophy, which is of course a combination between rickets and hyperparathyroidism, skeletal dysplasias, like mucopolysaccharidosis, Morkin's disease, laterophyseal injuries, of course, malunited fractures, Cosen's phenomenon, which is fracture of the proximal tibia alone, which results into valgus drift of the proximal tibia. This is usually a self-limiting problem, although I've seen cases that needed further correction, but mostly they resolve without treatment. MHEs, or multiple hereditary exostoses, commonly result into valgus knees. This is one kind of epiphyseal dysplasias with, as you can see, the femoral heads are abnormal, the ankles are abnormal, the knees, of course, are abnormal, and of course the upper limbs, of course, are also abnormal. And one of the deformities this girl was valgus knees. This is mucopolysaccharidosis type 4, or Morkin's syndrome. He has multiple skeletal abnormalities, even chest cage, distal radius and ulna, and valgus knees as well. Rickets is a common thing we see, and to my surprise, Campo, which is a major textbook in orthopedic surgery, has this X-ray in the middle to show for rickets. And they haven't seen our version of rickets, which is severe, long-standing lack of vitamin D, with all signs very, very well apparent in the X-ray, like fraying, increased height, widening, broadening, cupping of the physes, very, very characteristic and very recognizable. Rickets in adolescent girls is one thing we see a lot in our country. The physes are almost closing. The trioleate cartilage is fully closed, but the physes in the proximal femora and around the knee are trying to close, but they can't because there is no calcium deposition. The adolescent rickets can also result in later onset of deformities around the age of 12, 13 in girls. What to do? You treat the underlying cause. So do not be shaken by an appearance of severe bow legs in a child with advanced rickets. No, treat the cause and you might get full correction without the need to do any surgery. Like in this example, this is his active rickets X-ray, and this is 1 year after treatment with vitamin D and calcium. And of course, in other kinds of rickets, not the simple vitamin D deficient rickets, but other causes like phosphate diabetes, they need to be treated with phosphorus as well. And once these receive proper treatment, correction of the angular deformity can be achieved in most of the cases. This is another example of active rickets leading to valgus knees. When with good treatment, this is just 6 months later, and we see healing manifestations with still sclerosis around the physes. So the treatment is not over yet, but the child is getting better. Her axes are getting more and more aligned, and I'm sure further she might escape surgery and not need any. Some authors were speaking of bracing for valgus and varus knees. I'm not sure if this is really applicable. Growth modulation hemiepiphyseal is now the treatment of choice in skeletally immature patients. You make use of the growth potential, and you stop growth on one side of the physis and allow it to grow the other side. So gradual correction needs to be will happen. What you need to do to guarantee that this surgery you're doing is flexible, reversible. So you need to insert the plate in an extra periosteal fashion. You cannot damage the periosteum or damage the growth plate inserting the plate, and then when you remove the plate, you will end up with a fixed bar. So you will not have any chance at having a normal growth after you remove the plates. You start with the screws parallel, and they are said to diverge due to the tension band effect. Remove promptly when the deformity is corrected. So pick your patients. Do not insert 8 plates or tension band plates or staples in patients who are going to disappear for 4 years. You know, you need to be able to counsel the patients and tell them they have to come when the deformity is fully corrected so that you can promptly remove the plates. Rebound, it does happen. Some reports say it's not that bad. You do not have to overcorrect, but I've seen rebound happen in many cases. I'll show many people do to prevent rebound, or at least be readily able to manage rebound when it happens. Corrective osteotomy is, of course, the treatment of choice for those who are approaching skeletal maturity, who do not have enough growth potential to correct the full deformity or in higher grades or degrees of deformity. This is an attempt at correcting this severe valgus knees with medial hemiepiphysiodesis in the distal femur. Because we've measured the angles, the tibia appears to be normal. The deformity or the valgus is only in the femur, so correction at the level of the deformity was chosen. Severe valgus deformity in mucopolysaccharidosis kids can have poor potential to correct with 8 plates, and when it's so severe, you need to correct the angulation acute, and you need to as well osteotomize the fibula so that you can achieve good correction of the mechanical axis of the distal of the tibia. If you're correcting with an osteotomy, also choose the site of your osteotomy. So if as much as you can, you need to address the site of the cora. So if the cora is diaphyseal, I chose to correct this kid with a plate at the level of the deformity, because the deformity was not distal, it was mid-diaphyseal almost. And in a child, you are able to achieve full union without problems with plating in the mid-diaphysis. After a hemiepiphysiodesis, correction of this valgus knee was achieved, and it's time to remove the plates. Of course, after you repeat measurement of your axes and make sure the correction is full. Some people would like to leave or to give further 2 to 3 degrees of overcorrection to prevent the rebound growth that happens. It's not yet, it's still controversial. It's not. So what to do with rebound? Some authors suggest that you remove just 1 screw, so you lose the tension band effect. And if rebound happens, you can easily go in and put that screw again without going through all the trouble of exposure and positioning and so much X-ray to the doctor and to the patient. Overuse conditions, these we see in older children, athletics, active children, boys more than girls. I begin with Osgood-Schlatter disease, a similar condition, Larsen-Johansson disease, Pesant-Serinus bursitis. They, of course, all these occur around the knee, and they are characterized by happening or occurring in boys more than girls, adolescents, who are athletic. They are very active at jumping, running, and they are a type of traction apophysitis or epiphysitis at the insertion of the patellar tendon. A traction injury can be associated with patella alta. The boy usually presents with a painful, tender swelling at the site of the tibial tuberosity, unilateral or bilateral. Usually the treatment is conservative because all he needs is rest and anti-inflammatory to decrease the traction injury that happens and that has caused the apophysis or the terminal fibers of the tendon to inflame. This is the characteristic appearance on the X-ray lateral view. You see fragmentation of the apophysis at the tibial tuberosity. Second entity is a similar thing that happens, but instead of at the tibial tuberosity, it happens at the lower pole of the patella. Again, jumping exercises, active young boys. Treatment is again symptomatic, rest and anti-inflammatory. And usually this ossicle or this fragment fuses back into the patella later on. Pes anserinus bursitis is actually pain and swelling with tenderness over the anteromedial aspect of the tibia. This is where the sartorius, gracilis, and semicondinosus tendons insert. All it needs is cold compresses, rest, anti-inflammatory, and the child can then resume activity as pain allows. It is seen with other patients with osteochondromatosis because this is a common site for osteochondromata, but mostly with athletic boys. Usually this is the type of patient I see. I'd like to recommend further specialized issues in the pediatric knee, like osteochondritis dissecans, patellar maltracking, patellofemoral instability, and the big issue of knee problems with CP. The knee carries the burden of those ambulatory CP children who get a little older and a little heavier, and then they crouch. The knee, in this case, carries a lot and needs to be treated with really very specialized surgeries and care and bracing. So I do recommend these further topics for everyone to read through, because it's not very simple to lay here in front of you. It has to be very specialized, and you need to be able to assess the patient fully. So good knowledge of CP children has to be there when you are treating knee and CP kids, and of course sports medicine in patellar maltracking or osteochondritis dissecans. Thank you very much.
Thank you so much, Professor Nariman, for this very comprehensive and very interesting all the orthopedic problems and pediatrics of the knee. Thank you so much.
You're very welcome. Thank you.
Dr. Anand, any questions to Professor Nariman?
في أول سؤال دكتور محمد وائل. In habitual patellar dislocation, what is the surgical treatment and the preferred age of intervention?
You intervene when there is symptoms, the knee and the ankle, or the hip and the knee, but it is a single cord-like structure that causes flexion or webbing and a contracture of that joint. Of course, it can be bilateral, but arthrogryposis is a condition where many joints have abnormal motion because the muscles are fibrotic and tight. This is different. This is a different entity. Could you remind me with the other questions? MPFL reconstruction is exactly what I explained. Is you need to reinforce the medial structures. Of course, when you have a lateral patellar dislocation, the MPFL is not in its normal capacity, so you need to reinforce it by a tendon or by plication of the medial capsule and overlap. You suture the capsule, the medial capsule on top of the patella, but you need to use a tendon. I used one of the SGS complex tendons. I'm sure I missed two questions in the middle.
In severe Jonoverum, yes.
Oh, yes. If a child has a normal calcium profile, I'm not speaking about lab workout. I'm speaking about the x-rays. If you see no rickets whatsoever, normal bone ossification at the physes, it can be a dysplasia. It can be dwarfism, can be achondroplasia. So you can have other causes of severe varus other than rickets, of course. In that case, you do not expect improvement after the age of 3, because that should actually be the age of physiologic valgus. So in that case, go ahead and correct, but you make sure you measure correctly. So you need to measure the axes, the mechanical axis of the femur, mechanical axis of the tibia, to detect where exactly the deformity sits, and then you correct at that site of the deformity. Instead of creating 2 deformities. If the deformity is in the femur and you correct the tibia, you're creating a problem rather than fixing it.
تمام. في سؤال كمان من دكتور شريف فرج in Assiut modification of activity.
Well, usually it heals at skeletal maturity because the apophysis of the tibia, of tibial fibrosity, closes. One of the complications that were rarely seen was premature closure of the physis at that side, resulting into recurvatum, severe recurvatum of the knee. But this happens very rarely. I have never seen it. It's just, you know, it's in the literature. So it will heal eventually when the child gets skeletally mature. It usually stops being painful much earlier than that, as long as the traction injury is less, the area has time to rest and to heal, then the child can resume activity when the pain resolves. Usually the swelling stays, unfortunately. The swelling stays in skeletal maturity. Usually they complain of that bump later on.
Another question from Dr. Ismail Siam. Please, for neglected lateral patellar dislocation more than 2 months with tight lateral structures now, what is the best surgery and what prognosis for those cases?
So are you speaking of traumatic patellar dislocation? I think you're speaking of
neglected case of lateral patellar dislocation.
Of more than 2 months, he says. So
more than 2 months.
He's probably speaking of trauma that resulted in MPFL rupture or disruption, and then this is included in the subject of patellar maltracking and traumatic patellar dislocations, and this is a huge subject. But basically, you need to restore the alignment and then reinforce the medial MPFL, of course, the medial patellofemoral ligament. I will not go through it. It's not my specialty. I send these to sports medicine colleagues, of course.
No other questions, Dr. Mohammed.
Yes. Thank you so much, Professor Nariman, for this interesting talk. And وجود حضرتك معانا النهارده شرف لنا يا فندم والله.
فندم شرف لي، ألف شكر.
الله
خالص، شكرا جزيلا.
ربنا يخلي حضرتك.
سعيدة جدا بوجودي واشكركم على الدعوة. شكرا.
اسعد يا فندم، وكليه طب اسيوط كلها معانا في الكورس بصراحه، يعني كلهم اساتذتنا بصراحه. كلهم كانوا معانا في الكورس من الاول، وتشرفنا بوجود سيادتك معانا النهارده يا فندم.